Here we'll address major aspects of dementia. We'll focus on Alzheimer's disease, which accounts for roughly 70% of dementia. At its core, it's a disease of progressive short term memory loss. Vascular dementia, which accounts for roughly 15%, it manifests with a classic stepwise progression. Lewy body dementia, which accounts for roughly 10%, we can think of it as having a combination of both dementia and Parkinsonism. Let's begin with Alzheimer's disease pathology. We'll start with early areas of brain atrophy. Draw a coronal MRI section and illustrate that there's prominent temporal lobe atrophy. Then draw an axial MRI section and illustrate prominent parietal lobe atrophy. Generally, the temporal and parietal lobes are affected early on in the disease. This finding correlates well with some of the key symptoms of Alzheimer's: memory loss and language dysfunction of the temporal lobes, and visuospatial dysfunction due to involvement in the parietal lobes. Now within the temporal lobe shows severe degeneration of the hippocampal formation. Show a normal hippocampus for comparison. Next, let's indicate a few key histopathological findings. Amyloid beta plaques, senile plaques, which are extracellular aggregates of fibrillar amyloid beta peptide, tau neurofibrillary tangles, which comprise intracellular conglomerations of hyperphosphorylated tau, a microtubule stabilizing protein, Hirano bodies, intracellular eosinophilic rod-shaped structures that comprise multi-layered actin filaments and binding proteins. Next, let's introduce some clinical pathologic correlations in Alzheimer's. In early Alzheimer's, short-term memory dysfunction from hippocampal degeneration occurs, word finding and naming issues from temporal lobe degradation occurs, and task sequencing and visuospatial disturbances from parietal lobe degeneration can occur. We can look for apraxias on exam to identify these. Later in the disease, remote memory degenerates, neuropsychiatric symptoms become prominent, visual spatial dysfunction worsens. Think of trouble staying in a lane when driving or getting lost in familiar areas. When non-memory symptoms predominate, we can categorize patients as having an Alzheimer variant. They include primary progressive aphasia, a frontal variant, which manifests with behavioral dysfunction early on, and posterior cortical atrophy, which manifests with visual spatial dysfunction early on. Next, let's address some of the best known genetic factors in Alzheimer's. Indicate that the best established genetic risk factor in Alzheimer's involves the apolipoprotein E gene. Specifically indicate that the ApoE4 gene allele increases the risk of Alzheimer's, whereas the ApoE2 allele decreases the risk. List 3 key mutations linked to autosomal dominant early onset Alzheimer's: amyloid precursor protein, presenilin 1, and presenilin 2. Finally, indicate that in trisomy 21 there's APP gene triplication, which increases the risk of early onset Alzheimer's. Let's address some key aspects of Alzheimer's treatment. There are 2 main classes of symptomatic management. First, indicate cholinesterase inhibitors, which increase cholinergic activity. As we might predict, these cholinergic effects commonly cause GI hypermotility, and worrisome symptoms are bradycardia or cardiac conduction abnormalities, and possible COPD or asthma exacerbations. Cholinesterase inhibitors are donepezil, rivastigmine, and galantamine. Next, indicate that memantine is an NMDA antagonist. It reduces glutamate excitotoxicity. It can induce confusion and hallucinations, which are already possible complications in patients with dementia. No disease-altering medications have proven substantially effective, but drugs are in development. It was promising but disappointing when drugs designed to clear amyloid plaque failed to slow the progression of the disease. Now let's address vascular dementia. We'll ignore the cognitive burden from large vessel infarction, and instead we'll focus on 2 key common causes: multi-infarct dementia, a small vessel disease, and cerebral amyloid angiopathy. Multi-infarct dementia classically presents with a stepwise decline in cognitive function. Draw an MRI image and show confluent white matter disease to illustrate the accumulation of microvascular disease centrally. Management depends on vascular risk factor modification. Cerebral amyloid angiopathy is characterized by dementia in the setting of microhemorrhages and lobar hemorrhages. Draw a blood vessel from central to peripheral, show the intima, media, and adventitia. Indicate pathological invasion of amyloid beta plaque in the walls of cerebral cortical small and medium-sized blood vessels and leptomeningeal arteries. We show amyloid in red because, as we discussed with Alzheimer's disease, it stains with Congo red staining. It's congophilic. Amyloid accumulation causes microaneurysm formation, rupture, and bleeding. Overlap exists between amyloid accumulation in Alzheimer's and in cerebral amyloid angiopathy. Using an MRI sequence that highlights blood products in black, an axial gradient echo image, show a stippled appearance of microbleeds within the cerebral lobes peripherally, and also show a large lobar hemorrhage. Amyloid angiopathy can present with spontaneous lobar intracranial hemorrhage, TIAs, so-called amyloid spells, subarachnoid hemorrhage, or simply as a slowly developing dementia. Management involves reduction of bleeding risk through blood pressure management and modification of antithrombotic agent use. Next, it's helpful to divide Lewy body dementia into two main categories, dementia and Parkinsonism. From a dementia standpoint, indicate the following prominent symptoms, in addition to memory loss: visual hallucinations, delusions, specifically indicate Capgras syndrome, which is also known as imposter syndrome, in which patients are convinced their spouse or caretaker has been replaced by an imposter; severe fluctuations in level of arousal with sudden sleep attacks. From a Parkinsonism standpoint, indicate the following prominent symptoms: symmetric rigidity, typically without tremor; gait impairment, show frequent falls to remind ourselves to ask about this important symptom in our interview. These symptoms will have a limited response to dopamine. Also, severe neuroleptic sensitivity, meaning typical antipsychotic medications such as Haldol will profoundly worsen the Parkinsonism and can even lead to neuroleptic malignant syndrome. REM sleep behavior disorder, in which patients act out their dreams due to dysregulation of muscle atonia during REM sleep. To show a cortical Lewy body, draw a nucleus within a cortical neuron and then include the Lewy body inclusion. They have a more uniform density of alpha-synuclein and ubiquitin than the nigral Lewy bodies do. To show a nigral Lewy body, draw a cell body from the substantia nigra with its signature neuromelanin pigment. Indicate that with alpha-synuclein staining, there's a central clearing with a peripheral halo of alpha-synuclein. Show that on H&E staining, the Lewy body has an eosinophilic core with a peripheral halo. Lewy body dementia has a significantly worse prognosis than Parkinson's disease and does not respond to dopamine as Parkinson's does. Next, return to our table and indicate that for routine dementia workup, everyone should get brain imaging, CT or MRI. It's key to rule out subdural hematoma, which can present with subacute cognitive decline in the elderly population. For routine laboratory workup, all patients should have B12 testing. We include methylmalonic acid and homocysteine levels if B12 deficiency is suspected. And thyroid testing. There's a complicated relationship between thyroid disease and dementia. We especially need to be sure to exclude myxedema madness as the cause of the cognitive symptoms. Lastly, let's list out some common related diagnoses in dementia. First, delirium is a common condition in the elderly hospitalized patient population, occurring in roughly 30% of patients. It manifests with alterations in alertness, attention, and cognitive processing. Patients have fluctuations in consciousness, inattention, abnormal thinking, potentially with delusions and hallucinations. Transient global amnesia is a syndrome of transient anterograde amnesia, typically 24 hours in duration. Patients can access remote memories but have a temporary inability to generate new ones. Wernicke encephalopathy is secondary to thiamine B1 deficiency. It presents with ataxia, delirium, and ophthalmoparesis. We want to avoid it transitioning to Korsakoff syndrome, which is chronic and irreversible. Finally, include mild cognitive impairment, which describes a dementia prodrome. Patients who have cognitive dysfunction beyond what is expected for normal aging, but do not yet meet the threshold of dementia. This concludes our diagram.